Hi, good afternoon. Thanks for coming. So we have a special guest with us today, Dr. Kate Comtois from University of Washington. I'll read Dr. Comtois' bio to you. You'll get a sense of all the things that she's done in our field. Very diverse skill set, really a triple threat, which is hard to find in our line of work, where she's won awards for her teaching, for her clinical work, and for her research accomplishments. So really excited to have her here. A little background. Kate has served as one of my primary mentors throughout my young career in psychology and trying to become a clinical trials researcher and doing health services research. So it's really special for her to be here today because she's really impacted my career. So Dr. Comtois, her career goal is to give suicidal clients and their clinicians their best chance to succeed. She's been working in the area of health services, treatment development, and clinical trials research to prevent suicide over 20 years. Her graduate training was in community clinical psychology and focused on achieving clinical ends through prevention and other system interventions in socioculturally diverse populations. She has developed and adapted interventions to improve care and clinician willingness to work with suicidal patients, including dialectical behavioral therapy, collaborative assessment and management of suicidality, caring contacts via text message, and preventing addiction-related suicide. She's developed DBT ACEs, a program to assist psychiatrically disabled individuals with borderline personality disorder find and maintain living wage, employment, and self-sufficiency. Dr. Comtois' research has been funded by the National Institute of Mental Health, the American Foundation for Suicide Prevention, the State of Washington, and the Department of Defense. So please help me welcome Dr. Comtois.
Thank you very much. As Stephen and I usually do, let people know kind of how we met, which was Stephen was my supervisor on a research grant that we were doing CAMS, which, as I'm sure you all know, is one of his major areas of expertise, and so he took over some of the supervision, and I tell you, great supervisor from, what was it, third year of grad school, probably at that point, and we've worked together since, so it's been it was a real honor and pleasure to be invited to come and present with you today. So what I'm going to talk about today is DBT. Oops, just going to move this mouse. Okay. Backward. There we go. So I want to talk a little bit about DBT, just give you a brief overview on the research data, and rather than present a bunch of research slides, I'm going to try to summarize it in terms of different structures of DBT. People have implemented DBT in a lot of different settings, a lot of different formats, and so I'm going to talk a little bit about the empirical support in terms of that. I'll introduce you to the biosocial theory, which underlies DBT, how the treatment is organized around goals and targets, and I'll spend a block of time on chain analysis, which is the core way that we assess problems and difficulties in DBT, and talk a little bit about validation and dialectics. So the original format of DBT was developed in the early 1980s as a research clinic within a department of psychology. So Marshall Linehan was working at the University of Washington, Department of Psychology. So the best equivalent, I at the Department of Psychiatry and Behavioral Sciences at the University of Washington in the School of Medicine, so I'm kind of in the same environment you are. I've been based at the Community Mental Health Center that's attached to our medical center. So I'm at Harborview. It's the downtown, you're found down, the police are bringing you, you need to be airlifted, we're that kind of county hospital. And we have a mental health center attached to that. That's what I've been doing most of my career. And it's the first place that DBT was exported outside of Marsh's research clinic. So from my point of view, like thinking about a research clinic in a psychology department is it's a pretty unusual format. So probably the best analogy I think for it is a team of sliding fee private clinicians. That's really how a clinic in a psychology department tends to function. The core treatment in DBT is individual psychotherapy once a week, plus a skills training group, because there's a fundamental belief that the clients don't have skills that they need to actually achieve their goals. Then there's, as most people know, this is usually what gets people most concerned about DBT is out-of-session coaching, which is is available according to the therapist's personal limits. So that can be as much as 24/7 or significantly less than that, depending on who the therapist is, what their approach to their time outside of work is. And then there's a consultation team. So in the original program, that was about 90 minutes long. And what they found in repeatedly across studies is reductions in suicide attempts and self-harm, emergency rooms, inpatient units, lower dropout than you would typically see with treatment for borderline personality disorder and chronic suicidality, and overall cost savings. So if you look at DBT where in a VA system or other system where you're capturing both inpatient and outpatient costs, DBT is usually a cost offset situation. There's actually a savings to the organization for implementing DBT, often in inpatient psychiatric days, ERs, and if you can actually, where I've seen the largest cost savings is if you're actually incorporating the medical costs. So one overdose, for instance, resulting in an ICU visit is a lot of money that there's no outpatient treatment in the world that's going to cost more than that. The evidence suggests that you can improve kind of core baseline functioning. So a lot of people early on were thinking that DBT was only going to be effective for kind of the symptoms. This is just a kind of a surface treatment that people often thought that way about sort of behavioral treatments in general, especially in the early 90s when the initial research was coming out. But there's been research since showing changes in much more fundamental levels of functioning that are sustained after treatment is over. And it has this real benefit that it tends to succeed with the most extreme cases. So whereas other treatments, they're fine unless you're too complicated, in DBT there's rarely a too complicated. And if people have questions about that, we can talk later about kind of what makes you sort of too complicated for DBT. The downside is it's pretty intensive as outpatient treatment goes. So it's usually a year. The shortest programs are usually 6 months. So we're talking if we're saying individual and group every week, we're talking about somewhere from 50 to 100 sessions. This is vastly bigger treatment than you would see for most CBT-oriented interventions. This is a kind of, especially if borderline personality disorder is involved, this is something that's very treatable and doesn't respond well to kind of surface attempts. Like almost every treatment that's been shown to work for borderline personality disorder is at least a year long with weekly sessions with a fairly expert clinician. That is the kind of ballpark that makes change happen for people with their borderline personality disorder. The other issue is that this means that there's increased outpatient costs. It's an expensive program to run in an outpatient context, and what that means is that it is not a cost savings unless you can see the savings on the ER and the inpatient, on the medical side. And so sometimes the reason it doesn't get implemented or it doesn't get implemented well is those costs are not connected. So in our civilian system that we have in Seattle, there's no connection at all. And so we're constantly taking only the most severe cases in our community mental health center into the DBT program because they're the only cases we can get paid enough by the county and the state that the dollar figure comes close to covering the costs of the program. The other thing is this is an intervention that really requires fidelity. I don't have a whole ton of faith that you're going to change baseline functioning with a poorly run DBT program. What you can do is you can reduce chaos from the patients with a poorly run DBT program. And so I frequently see programs that are poorly run and sustain that way because they've managed to sort of reduce the chaos these patients are kind of causing the system, and I'll kind of come back to that point. So residential programs, so what these studies talked about as inpatient in their studies, but that's because it's in Germany, and in Germany what they call inpatient is what we call residential. So these are 3-month-long programs, and there have been multiple studies. This is the only one that is represented in a randomized clinical trial, and you can see they have kind of comparable costs, but of course it's a long length of stay and not comparable to what we usually have in the U.S. This is a standard version of comprehensive DBT in the public mental health system, so this is the way we've done it in our program. We offer 2.5-hour groups now. When we did this evaluation in the early 2000s, our groups were 2 90-minute groups, so we would cover half the material and the other half because it seemed like it was more effective for some of our chronically mentally ill patients to come in more often, and frankly, they didn't have a lot going on. As we've kind of moved through the recession, one of the things my county hospital did to survive the recession was for every program that could bring in commercial insurance funding, they made a huge push. So they told us, we need you to get 50% commercial funding. And a lot of those folks are working, and they can't come in twice a week. So we offer groups both ways. We offer out-of-session coaching during the work week, and our therapists vary in terms of their after-hours availability. So we have we have a contract with our local crisis clinic to provide backup if that's needed. We have a 2-hour consultation team, and then medication and case management is integrated into our community mental health center. So it's available if it's needed for any given patient. What we found is in our doing an evaluation of our program, comparable outcomes to the research studies, and that we've done this meeting all of the state and county guidelines. So this is an evaluation of a community mental health treatment done to follow every Medicaid rule, every Medicare rule. I spent most of my life trying to figure out how to keep a DBT program alive in the face of public funding issues, and now I have to figure out how to do it with public funding issues and commercial funding issues. So it's been quite an interesting ride. Again, it's an intensive service, which means higher outpatient costs, and there's real infrastructure changes to way community mental health is usually conducted to be able to make this work. Weekly individual therapy for a year is really rare, certainly on the West Coast in terms of community mental health, where therapy has not had kind of a standing since probably the late 60s and early 70s. So that is one barrier that most of the community mental health centers in my community have not adopted DBT in a comprehensive way because they cannot figure out a way to make it work financially. And we have some of the benefits of being tied to the medical center and things that make it viable for us. So this is a study that came out a few years ago, conducted in Norway, of an adolescent DBT program. There have been other non-randomized studies done of adolescent DBT, and Marcia Linehan just finished an adolescent trial in the U.S. that data should come out probably sometime this year. But this, I'm just going to kind of refer to this trial because the randomized clinical trial data is already out. So they did weekly individual therapy. The program was 19 weeks long. The different adolescent programs have varied 19 weeks, 16 weeks, 26 weeks. What is that, 6 months? Yeah, 26 weeks. So it's usually shorter. The groups are run as multi-family groups, which means the kid and at least one parent or caregiver or volunteer, if they've got nobody else, are coming together. And both folks are learning the skills for their own use. So it's not that the parent is coming to coach the kid. The parent is coming and they're taught the skills the same way. They have to come back and report their homework in the same way. So everybody's learning the skills together in this multifamily skills group. There's family therapy and out-of-session coaching is needed, and then a consultation team, which is a core part of DBT. So what they found is reductions in self-harm, suicidal ideation and depression compared to a standard treatment comparison group. Treatment was more rapid improvement, and again, they were succeeding with really extreme cases. So again, DBT has that benefit. And again, expensive and requires a lot of fidelity to the model. Recently, people have been studying DBT skills by themselves. So Shelley McMain in Toronto did a large clinical trial of DBT skills versus a waitlist control. And Marshall Linehan did a study of DBT skills with no individual DBT. You had a case manager you could see fairly intensively. She had a DBT individual component where you had a DBT individual therapist, no skills, and the therapists were not allowed to talk about skills, and then the full DBT condition. And the results have found in comparing to waitlist, the skills alone, no individual at all, showed reduction in self-harm, inpatient treatment, anger, anxiety, coping skills, and of course the cost was much lower than a comprehensive DBT program. The results look like they might be less durable. The differences seem to kind of, by follow-up points, the control and the DBT were starting to look more the same. And there were almost everybody who ended up in group-only conditions still had a fair amount of individual, just wasn't a DBT individual. So it's unclear that the costs of DBT were lower. I'm not sure the overall health services costs were actually lower. And then this is a meta-analysis my current postdoc, Krista Koo, and I are just finishing and have submitted to behavior therapy, looking at doing a meta-analysis for self-directed violence, that is suicide attempts or non-suicidal self-injury or other suicidal behavior, and looking across trials. You can see, if you're not used to looking at these kind of plots, what you're looking at primarily is the diamond at the bottom. 0 would suggest that the intervention is not having sort of, what you want is to have improvement of the intervention over control. So being on the left side of the line means the intervention is better than the control, and obviously we don't want it to be on the right side of the line. The length of the line represents kind of how variable the results were, and the size of the box represents the size of the sample. So a study with a large box had a bigger influence on the results because it had a larger sample in the meta-analysis. So what we're seeing here with the diamond is the overall result, which is left of the line with a fairly narrow confidence interval, which says we can be fairly confident that in fact there is a small but consistent benefit of DBT over the variable control conditions. You see a similar pattern for emergency and inpatient services. And we're right at the line on suicidal ideation, which was measured in fewer studies and, is right there on the line, so could be chance. And then the last thing I just want to comment on before I stop talking about data, something we don't have any data for, which is what typically gets called in the DBT community, DBT-informed treatment. So this looks like things like incorporating DBT into your individual therapy in sort of a somewhat haphazard way, or only incorporating the parts that you like. DBT skills that are teaching the DBT skills, this particular skills curriculum, but the group leaders aren't using any of the other DBT treatment strategies. Doing DBT sometimes, but not consistently, and one that we see a lot is doing DBT unless a crisis occurs and then jumping out of the model. Which is a problem because so much of what makes the model work is what you do in a crisis. So if you jump out at that point, then you're kind of jumping out at just the point where DBT could have been making the biggest difference. And of course, the pros of this are it's incredibly easy to implement since you could be doing almost anything. There's generally no increase in your outpatient treatment costs. You're probably just incorporating this into your existing programs. No fidelity, obviously, is required, but it is less likely to improve the outcomes for clients and does not necessarily do a good job with extreme patients. In fact, sometimes you can make it worse. But the thing that I really like to highlight, because I think I've seen over and over and over again over the last 20 years, is clients think they had DBT, they think it didn't work, and they won't go back to a comprehensive program. And I think that's actually a really tragic outcome. And I get calls all the time from people who want their client to come to our program. How can we get your client into DBT? And I'm like, well, have the client call the number. We'll get them on the list. Well, they don't want to come to DBT. How do we get them to do it? What? And it just turns out that they've had what they thought was DBT that was either not done well or just a group or whatever. They need a really comprehensive program, but they're really unwilling to try it. So I do think that's an important implication for just kind of throwing a little DBT into what you're doing. What I would recommend if you don't want to do the whole comprehensive program is, like the skills only, pick one piece and then do that one piece to fidelity. Like when we're now studying skills group done to fidelity with the consultation team to support the therapist, we are seeing good results from that. Okay, so enough about data and treatment structure. What I do think is really important for folks to understand about DBT is what is the underlying theory that the treatment is built on. It'll tell you a lot about who you'd want to refer to DBT, who's likely to benefit from it, and what do we think is actually happening. So historically, theories of borderline personality disorder have had built on concepts of underlying anger, abandonment, failed sense of self, inability to mentalize, which is this concept of the ability to see outside, see how somebody else's experience is truly separate from your own, and that your view of what's happening with somebody else is not in fact what's happening with somebody else, a concept that we see folks with BPD struggle with a lot. And DBT has a pretty different idea of what's happening. So it's based on a combination of, it's a typical nature-nurture, right? So it's built on a combination of sort of what is the biology you were born with, or a biology you've been given due to congenital issues, traumas, other things that have shaped you biologically to be differently constructed and cause you to have problems, and then the social side. So the idea, and this was the original theory in which the treatment's been built. There's been moderate empirical support for it when people have been studying the theory and looking at folks with BPD compared to people without BPD. I would say that the empirical support is moderate, but I think it's so heuristically helpful that it is really the best way to think about DBT. So one of the things to think about is that the problem that the person who has borderline personality disorder or chronic suicidality, the problem that's happening for them is in part that they have an extremely sensitive emotional system that biologically, by temperament, for a myriad set of reasons, very, very small cues trigger an emotional reaction, right? So when I'm talking to patients about this, or teaching therapists to do DBT, I get people to think about just the variability in the people you know. Like if you think of the people in your family or the people who you work with, and you think if the variable responses people might have to walking into the elevator and getting pushed from behind so you bang into the back of the elevator. People would vary, at least in the people in my life, from being totally terrified by that to being like, yeah, whatever, right? I had one of the managers in my clinic, we have sort of this, she's absolutely not sensitive. And the example I often sort of point out is that somebody literally was climbing in her bedroom window in the middle of the night one night, and she got up and yelled, and they ran off, and she called the cops, and they came by and swung around looking and took the report, and then she went back to bed in the same bed, right? That night. Many of us could not do that, right? That would have been a trigger that would have, for sure, set off intense emotional dysregulation. It didn't for her. So there are people who are like that. They're just unflappable people. And folks with borderline personality disorder and chronic suicidality tend not to be unflappable. They tend to be folks where even small cues, cold water in the shower in the morning, having a remark said that was ambiguous, could be critical, might not be. These small triggers kind of set off an emotional fire for them. And because the triggers are small, there's many more of them. So they're dealing with more hits all day long, right, than other folks are contending with. They have increased reactivity. That is, once it's triggered, they tend to have a bigger reaction. So if you bumped me and I hit the back of the elevator, I would probably get a little startled, maybe a little anxious, maybe a little irritable. My clients would be terrified, furious, overwhelmed, humiliated. Just the scale of the emotional reaction biologically is much bigger. Lastly, that there's a slow return to baseline. That is, once that fire is started, it doesn't just go out, right? And we're all probably different about this with different emotions. I'm the kind of person, if you piss me off, I'm mad for a minute, 2 minutes, 10 minutes, and it's over. I don't sustain anger very well at all. But if I get embarrassed by something, I've been known to think, there goes the afternoon. Because that will not come down for long periods of time. Every time I think of it, it re-triggers, right? And you get this pattern where one cue triggers more arousal. The way you think about the situation makes the arousal even higher. Then you may do things in response, like turning around and yelling at the person who bumped into you, only to discover that person has a cane and tripped, or otherwise is a little old lady or somebody who now you're humiliated that you made such a big deal. And you get, they have a reaction to you, like, what's wrong with you? Now I'm scared to be in the elevator. Now I want to get out of the elevator because I'm now upset with you, right? And you end up with this kind of continuous high arousal. And that's often how we see patients. And for those of you who are dealing with the emergency room and the inpatient unit, you really know this is what you're seeing, right? Because by the time they get to you in a crisis situation, this has been building, and that arousal has often been high, it's been sustained, they haven't been able to sleep, and other things are happening that have further exacerbated it. And we all have a problem with high arousal. High arousal is associated with poor cognitive functioning, right? It's that thing where you end up in an accident on the freeway, somebody rear ends you, and you've pulled off the highway, and your car is, the back of your car is wrecked, and you're totally freaked out, and the police officer comes and they say, "What's your address?" And you got nothing, right? You simply cannot engage your cognitions when your arousal gets high. So this is something that our clients struggle with a lot. One of the places that I think of this is most sort of kind of tragic for everybody concerned is family meetings at the end of an inpatient stay. Do you guys do this? Have family come in and staff, and we're all having a meeting? This tends to be extremely dysregulating for a lot of my clients. Either they have dysregulation about leaving, they have dysregulation about dealing with the family, or they have dysregulation about dealing with you or coping independently, or for a lot of reasons, they're often highly emotionally stirred up by the time the meeting is even starting and sort of will continue. Sometimes family says something that sets it all off, or just the mere fact of discharge is setting it off. And their cognitive, the thing to really remember is that this is meaning they're going to have very poor cognitive functioning. So they don't necessarily handle themselves all that well in those meetings. And then I'm sure you've all dealt with the fact that 2 hours later, they have no memory of what they just committed to, right? There was a whole plan. It's as if you never had a plan, right? It's in part because they literally aren't processing this information. And it can be really important to work with them ahead of time, to be prepared for the meeting, have stuff written down, go over it again with folks, not presume that they actually know what happened in a situation like that. The other half of the biosocial theory is the environmental half, which is what we call in DBT the invalidating environment, right? So there's three main components that we think are sort of characteristic of an invalidating environment. The first is pervasive invalidation of the child's private experience. So when we're talking about invalidation here, we're talking about it as is the experience of the individual that they have internally mirrored by the feedback they're getting externally, And pervasive invalidation is where you have an internal experience and the environment is acting as if it's not real, it's not true, it's not valid, right? So I grew up in a family where being very emotional is not okay. My dad manages it by being a very routine guy. He does all of his health behaviors. He does, my mother just isn't emotional. She's one of those people who kind of, whatever. Right? And so me being emotional to them, I was reacting as if a catastrophe was happening. Right? And it wasn't pervasive, thank goodness. But there were these moments when they were like, that voice would be really good on the stage, Kate. Or, you've cried long enough. Don't you think it's time to stop crying? Right? This is the kind of, and you can see that this would vary for people who are very emotional. So, the kind of difficult to soothe kid, just born by temperament, very difficult to soothe, is going to end up in that environment more often. But an environment is also going to be more likely to be invalidating if it's overstretched. Right? You often see BPD in a family with a sibling with a major medical condition in childhood. Right? So all the attention was focused on the sibling's cancer or the sibling's cerebral palsy or whatever, and this emotionally dysregulated kid was regularly not getting validated for the problem that they have that wasn't as visible as the problem that the medically ill kid was manifesting. One of the really classic but traumatic stories from Children's Hospital in our community was a kid who was having a lot, and it had been really long-standing emotional problems. Things were going worse and worse for his mom. They got a divorce. One thing led to another. So she was living in her car with 4 kids, right? So she was doing the best she could with no place to live and 4 children. And his needs were not getting attended to for very reasonable reasons until he set himself on fire. And once he set himself on fire, of course, all of Children's Hospital engaged, mental health, everything became engaged. But this wasn't a situation where the mom didn't care or was abusive or, sometimes this happens because the kid is in fact so biologically aroused in that way. Another thing is that an invalidating environment can be one in which displays of emotion are generally ignored, so that you express a low-level experience of distress and you're brushed off or ignored. But sometimes when the environment's just right, you actually do get help, right? So the situation with the kid in the car is a good example of that. We see this sort of thing where the kid who needs emotional support is not getting it in a classroom unless they escalate. And sometimes when they escalate, they actually get help. And sometimes when they escalate, they don't. And for the behaviorists in the room, we call this an intermittent reinforcement schedule. Right? What we're really dealing with in this situation is something that's actually very, very hard to break. So the individual learns to express their pain in a really exaggerated, by typical standards, exaggerated way. That doesn't mean they aren't feeling it at that exaggerated level, but many of us wouldn't have gotten to that point because a lower level expression of distress would have received help and support, right? So you see this a lot in families where there's reasons for neglect, for instance. And the last is oversimplification. People tend to say, if you just applied yourself, just calm down. If there's one thing to never say to a chronically suicidal or person with borderline personality disorder, don't say just calm down. That's like responding to someone with schizophrenia by saying just don't hear voices. This is the psychopathology that they're contending with. Believe me, if they wanted to calm down, they would calm down. If they could, if this was in their capacity. That's why skills are so important in DBT. So what you end up with this sort of transaction. So this is just sort of an example where the biology is transacting with the environment to sort of build toward these kind of chronic problems. So you can imagine a baby born with kind of that temperamental and biological kind of vulnerability to emotional arousal. the baby's temperament and emotional needs are really confusing and dysregulate the parent who was expecting this sweet child who they could just, hold and rock in a glider, and then the baby's needs then don't get met, right? Because the family is not prepared to know what to do when holding the kid and rocking the kid, and more physical contact, which is often quite difficult for these overstimmed kids, is happening. So in about 70% of families with someone where they've developed borderline personality disorder, there was trauma. So somebody actually hurt the child in some way or sexually molested the child. The trauma creates or exacerbates the arousal and their vulnerability to emotion, it's changing their biology. The parent or the caregiver cannot understand, doesn't try, or cannot effectively teach the child to regulate their emotions and tolerate their distress. Parenting is very, very difficult with an emotionally vulnerable child who easily becomes dysregulated to very intense levels and who cannot be soothed. So the parent starts giving up, or the parent is ineffective, and the child and the environment are transacting over time and generally getting worse, right? So this is the kind of scenario that we're typically thinking of with the biosocial theory. And what we believe that results in is pervasive emotional dysregulation. This is what we believe is the core undergird of what borderline personality disorder is, and also what you see in chronic suicidal ideation, regardless of borderline personality disorder. So the idea is that if we're going to have to treat it now, we have to deal with this emotional vulnerability. The metaphor I think of this the best is sort of if you can imagine that you've driven into a parking lot and driven over a rock, or something happened and you busted your fuel tank and the fuel is just dripping and dripping onto the parking lot. Most of us who know the physics of fuel know that if nothing comes along, that fuel is going to evaporate and go away, right? This is like getting no sleep, right? Not going through a period of chronic stress, right? Where if nothing triggers you, and you haven't slept for 2 or 3 days, you're functioning at work, everything's pretty ordinary, everything's pretty straightforward, eventually you'll get some sleep, right? It's like the fuel evaporating. But for these patients, there's also these stressors that come along. It's like dropping a match in a parking lot. In general, big deal. You drop a match in a parking lot. There's lots of little stressors. Hearing some criticism, having your supervisor tell you could do something better, not having somebody else succeed when you did not succeed, some form of embarrassment, some way that somebody committed to being there for you and then wasn't able to do it. Things that we often just roll with. The problem is when you pair these two together, right? If you drop a match in a parking lot where there's fuel, you're going to have a really big explosion. And this is what these guys face on a regular basis. So they become extremely emotionally dysregulated, and they do emotion-driven behavior, right? So their cognitions are lower, their emotions are higher. They're going to do a behavior to try to get relief from the emotional experience. So self-harm consistently has been shown to cause emotion-based relief. Suicide is seen as an escape from this unbearable, painful, overwhelming situation, but also drinking, shopping, all of those impulsive behaviors that you think about when you're diagnosing borderline personality disorder. So what we really have to understand is this is what they're facing on a day-to-day basis. And the more we understand what's happening for them that's driving all of this kind of ineffective behavior, all the ways that they're ineffective with you, all the ineffective things they do when they were supposed to do something effective and yet they don't, the more you understand what's driving it, the sooner you can figure out how to fix it. So what we're trying to do in DBT is to deal with that emotional vulnerability differently. We want to teach them about their emotions. We treat emotions as something to teach patients about the way we think of diet and exercise and hemoglobin A1C and blood sugar and insulin and all of these things as things that are core to teach folks with diabetes about, right? That the idea is through education and understanding of what's going on in your body, we will get better diabetic control. They have the same philosophy in DBT. That the first things these guys have to do is become mindful, as we would say, and be able to observe and describe their own emotional experience. And then we want to teach them specific skills that are in our DBT skills training manual to actually respond to each of the situations that arise. And then they have success, and their success means that there's not something to trigger future vulnerability, right? That's essentially the whole kind of way that DBT works. So, how do we actually achieve that goal? The first thing we do is build the treatment around what we call a life worth living goal, right? We focus the treatment on helping somebody achieve something that makes them want to live. And in this way, the DBT is at its kind of fundamental base, it's a suicide prevention program. It is really built on the idea that the lives that these folks are living is unbearable to them. And if we cannot improve the quality of their life, we cannot help them achieve their goals, then suicide will always be a risk. These emotion-driven behaviors will always be in play because they will always be triggered by not having a life that they like, that they would live for. And so we just are thinking about the same things that you and I and our neighbors and the people at the gas station and the people at church and the people in your kids' soccer team. What does everybody want, right? You know, we're thinking about things like friends and financial independence and a nice place to live and a marriage or a relationship or kids or any ability to go on vacation, all of these sorts of things. And the idea is that if you had these things, suicide just becomes a non-issue, right? In the face of having the things that make your life worth living, you wouldn't be thinking of suicide. You would have things you don't want to wreck by impulsive behavior. If you have no skills to stop your impulsive behavior, you'll still wreck it, right? So these are the things that have to come together. So the idea is that once you've figured out what the life worth living goal is, what would they want, which is often very hard for clients to talk about, so it takes some real clinical skill to get people talking about what they really want. Then you have to think, why don't you have it now? What are all the problems that you have that are why you don't have it? And these sort of illustrate some of the sort of classic problems that people who are chronically suicidal or have borderline personality disorder have. That is why they aren't married, why they don't have a nice place to live, why they don't have a decent income, why they don't have someone who loves them, why they don't have friends who call them every Friday night, why they don't have a job they're proud to talk about at Thanksgiving dinner, right? And what we do is we sort all of these problems into a particular target hierarchy. There's a particular hierarchy where we always put suicide and life-threatening behavior at the top, then therapy interfering behavior, which is anything they're doing or anything we're doing as clinicians that interfere with the therapy process. Then we treat anything that we would call quality of life interfering, anything that is meaning they don't have their goals, that the quality of their life is impaired, and we teach skills. And once they have behavioral control, that's our first goal, what we call stage 1 of DBT. Get folks behavioral control. What you sometimes find is that even after the behavior is controlled, they are traumatized by their own emotions. This might be a PTSD scenario. It's as often as not some sort of pathological grieving scenario. When people finally get behavioral control, and especially if it comes along late in life, they have a lot that they've lost. For kids who wanted that high school experience, but who were just, high school was a train wreck, or now they want to go to college, but they're going to have to go to community college because they were just a mess during that year. They needed to be preparing for college. People who are older it's now really too late to have a family, or they really wanted a professional career and it's really too late to go back to school. And now they could do these things, except that moment has passed. And so there's often a lot of grief. So our goal here is really focusing in on the quality of life interfering behavior, and as the behavior gets in control, traumatizing emotions, self-invalidation, lack of respect, But the belief in DBT is we have to get life-threatening behavior and therapy-interfering behavior out of the way first. And the reason I kind of call this out is that people often think that the point of DBT is to treat life-threatening behaviors and therapy-interfering behaviors. It's not. That shouldn't be where you're spending the bulk of your time. You want to spend the bulk of your time helping them get their goals, which is usually all of these lower targets. But the belief is if you're dead, we can't help you. And if therapy itself is not working, it doesn't matter what we work on, because it's sort of like trying to, build something with a broken tool, right? If the tool itself isn't working, you might be able to build it with a broken tool. Like if the wrench is snapped off when you're trying to put some furniture together, you could sort of tweak it and work at it, but you might just give up, and so might the furniture. In this case, given the furniture has an actual choice in the matter, and that you're going to be a lot better off to just stop and get the correct tool, and then very quickly you'll be able to achieve the goal. And that's what we find. If we keep working on suicidal behavior and therapy-interfering behavior, we can quickly kind of check those off the list, and when those are not interfering with therapy, we can really get a lot of work done. So one of the other things I want to highlight that's a little bit different about how we assess in DBT is that we believe the problem is pervasive emotion dysregulation, and emotions are very quick. Right? Does anybody know how long an emotion would last if just left entirely to itself? Right? The entire sort of emotional experience. If a loud noise suddenly went off in here and everybody jumped. Right? How long is that experience going to last? Right? Most people's emotional experience will go through a peak and an arc and a drop in less than 2 minutes. If you are in a situation where what's going on is getting recued, right? So if an alarm went off, it's probably not going to just stop instantaneously, right? Probably people are going to be wondering what's going on, and somebody's going to check their phone, and there's going to be things that'll recue it. Then we're talking about 20 minutes. But for our folks, when something bad happens, it goes on for hours and hours and hours, right? And part of that is that they're just recuing it and recuing it and recuing it. And what we want to do is help them kind of have a normal emotional experience, have things peak and fall, right? So to do that, we use what we call a chain analysis, which is a chronological, trying to create a chronological order of events in the literally seconds to minutes, because that's the problem. Is what they did is emotion-based. That's the arc of the emotion. If you study something over 10 years or you study what happened last week, that is not going to get you control over an emotionally driven, impulsive behavior that happened 20 minutes ago, right? And you can go at it for a long time trying to deal with the underlying issues and not change this problem behavior itself, because you're not kind of figuring out what's driving that behavior right in those seconds and minutes before. So the way we think about it is there is a problem behavior. Let's see if I can get, there we go. Here's our problem behavior: cutting, attempting suicide, drinking, screaming at your boss, running out of work, cursing out the nurse at the nursing station. And then there were some vulnerability factors. These were things that were going on in the background that made you vulnerable to the prompting event happening, not getting any sleep, chronic stress, homelessness, poverty, not having enough to eat, right? Then some prompting event will happen that will kind of set this chain of events off, right? Perhaps if you're a kid in a psychiatric hospital, it's somebody told you no, right? No, you cannot call your mom, right? And again, you can think of this prompting event as like the match and the vulnerability factors as like the fuel in the parking lot, yeah? And then a whole bunch of links happen: emotions, thoughts, physical sensations, urges, actions. And then there's consequences once they've done the behavior. There's short-term consequences and long-term consequences. And what we want to know is that entire minute-by-minute order of events. And the idea is that we're going to match the skills and treatment strategies in DBT to whatever we decide are the controlling variables. Not every link in this chain matters. Certain links are the key links that said we had to get to that problem behavior. If that link happened, we often talk about it as kind of the slippery slope. If you think of like a water slide, how far out on that water slide at the top can you go before you are going down, whether you like it or not, right? What are those links that are the link that kind of makes the rest of it inevitable? And what links happen but are actually kind of irrelevant? So you can think about it as sort of our goal in treatment is to intervene so that we can change these. So, for instance, if we got rid of the vulnerability factors, we would get rid of the problem behavior, right? So if the person wasn't overtired and overstressed and didn't have a place to put their stuff, so they have to get out of the homeless shelter, right, at first thing in the morning and carry their stuff where they didn't get any sleep the night before and they have barely found breakfast, they got a cup of coffee in them, so they just have enough stimulant, right, with no food to balance their blood sugar, right? If you could change that, if you could get them a place to stay with a doorknob and a door that locks, you may prevent the problem behavior, right? You just want to be careful that you don't get so caught up in solving those kind of core vulnerability factors that if it isn't changing the problem behavior, you don't keep staying up there and let the problem behavior happen. Because in those cases, you want something a lot closer to the problem behavior to stop it. You could prevent the prompting event, right? And that would get rid of the problem behavior. No match would actually fall and light the fuel. Main thing we worry about is cue removal, right? Removing a prompting event so it results in short-term relief to the client and potentially to yourself, because family often will do things to remove a cue, to remove something that's distressing to their kid so they don't get an escalation, but it doesn't help in the long term. My classic, as the outpatient provider, the classic for me is when my inpatient unit puts my clients on Ativan on the unit, and I just want to explode with frustration because it's massive cue removal. I mean, Ativan on the unit is like chemical cue removal. Nothing gets to you in the same way. So it just knocks a whole bunch of things that would otherwise trigger the patient out. But the patient doesn't come home on Ativan, right? So I get them back in my outpatient office without any of this, I don't have that sort of cue removal function, and I sometimes have them now wanting Ativan or withdrawing from Ativan or many of other sort of myriad problems. You can see this in terms of not giving, avoiding having a person work with a particular nurse because that nurse, they don't like that nurse. If I were in an ER and I'm just trying to manage my 3 hours with this person or 5 hours with this person before they leave, might be strategic. Just don't work with that person. Calms the whole situation down. And if you've got sort of a frequent flyer, somebody's coming into your ER over and over again, you can imagine the problems you're going to have down the line if they have a reasonable expectation that they can ask for a different nurse if they want to, right? Because that's what they learned from you. You can change the consequences. So one of the questions is short-term consequences. So short-term consequences for a problem behavior are almost always positive, or the behavior wouldn't repeat itself. Usually the most common short-term consequence is relief, right? So if you cut yourself, you often get relief from the emotion dysregulation or the derealization. If you demand a change from a nurse to get a different nurse, and that nurse is gone, you get relief from the distress that was caused by that nurse. Right, so that's usually quite reinforcing, but the long-term consequences are usually aversive, because if they weren't, we would call it an effective behavior, right? There's got to be a downside here somewhere. So usually it's that people don't like you, you get less than good quality care, you have a lot of shame, you have a lot of problems because you spent all of your money trying to feel better by going to Macy's, etc. So what we really pay attention to in DBT is not inadvertently reinforcing the problem behavior or failing to reinforce the skillful behavior. And this happens all the time in demanding mental health situations where the person who's behaving in a more effective way is actually getting less attention and less assistance than the person who's out of control, because we're just trying to manage a very busy service. And then you can change other links. You could help them have more effective thoughts. You could help them reduce their urges. You could change their actions. And that's a lot of what DBT is based on. It's matching different treatment strategies to the kind of link that is the controlling variable in this situation. And then in DBT, it's all about skills. If you add skills, then you can use skills to replace the problem behavior. And in DBT, we have these kind of behaviors to decrease. You'll see that kind of reflects the BPD criteria, and the behaviors to increase. These are the skills areas that DBT teaches. Mindfulness, interpersonal effectiveness, emotion regulation to actually make your emotions smaller, and distress tolerance, which has nothing to do with making your emotions smaller. It has to do with affect tolerance, the ability to sustain a high level of emotionality without engaging in problem behavior, without doing things to make it worse. That's usually how we teach the patients. So this is an example that I made as a present for a client who was graduating that I've actually found pretty helpful for clients and therapists to think about all these different places along the chain where the different DBT skills can be inserted to prevent the problem, or of course if the problem happens, it's too late, what skills you can use to gracefully manage the consequences to your behavior. So in DBT, that's the kind of main change strategies, right, is intervening with these strategies where the links are that are causing the person the most problem. But if you just go around doing behavior therapy with most borderline patients, you will constantly be told that you just don't understand. Anybody ever been told that by somebody who's emotionally dysregulated? That's what happens because from their point of view, you're asking them to change is a statement that you don't get it, essentially. So you've got to balance these treatment strategies. And this is one of the things that's unique about DBT is all of this change strategy, all the way we're going to fix those controlling variables on the chain, has to be balanced with acceptance strategies. So these are the core change strategies in DBT. So we talked about skills and skills training. We do that usually in a group format, but the individual therapist is constantly trying to get someone to use a skill rather than do the dysfunctional behavior. Contingency management, essentially behavior modification. A lot of similar things. DBT tends to be a radical behavioral therapy, so you'll see a lot of strategies that you'd see also in applied behavioral analysis, other behavioral activation interventions, ACT, acceptance and commitment therapy. We do a lot of exposure for all these emotions that are interfering, and we have a number of cognitive restructuring and contingency clarification strategies that we use for problematic thinking. And we're essentially matching the problem to the core change strategy and just applying the most effective strategy we can. And that is balanced with what we call in DBT validation strategies. So in this case, we're talking about validation in the sense of a scientific experiment validated another scientific experiment. We're not talking so much about validation in terms of being nice, right? We're talking about, is the internal experience of the patient being validated by the external world around them? Are people they're interacting with having a common experience? Is their experience well justified, based on facts, and making sure that we're giving clients really accurate feedback. What isn't validation necessarily is a lot of stuff we do with patients, soothing them, praising them, chit-chatting with them, kind of global, non-specific positive feedback. Sometimes this is validating, but if it doesn't fit the patient's worldview, it's actually invalidating. If you say to a patient, I'm sure you were doing the best you can, and they didn't think they were doing the best they could, you've actually invalidated them, right? So that kind of cheerleading, that kind of global positive soothing, sometimes is validating, but it isn't really what we're talking about doing. On the other hand, we focus a lot on figuring out what we can validate. We can almost always validate their pain, right? This is a highly emotionally dysregulated group of people. If they're sitting in front of you with a problem, they're probably feeling a lot of pain. And there's some piece of that pain that you can call out. Often, in most situations, I can, except for some people who do not want it pointed out, their problems are hard to solve. Most of my patients are very validated by me highlighting the difficulty of solving the problems they have, particularly if you're talking about a problem that is really difficult. Homelessness is not an easy problem to solve. Poverty is not an easy problem to solve. Depression is not an easy problem to solve. Chronic, treatment-resistant anxiety is not an easy problem to solve. People are very validated by that. Another is explaining their experience as it looks to them, really doing what we call in DBT phenomenological empathy. Can I get inside the head of the patient and experience it as they experience it? And also the struggle with their biology. We really believe that their brains and their nervous system, their endocrine system, their muscle tension, all of these things are driving their experience, and they don't have control over all of that. I have a lot of anxious patients where we can do the best progressive relaxation in the world, and it is a long time before their body will relax. Their muscles simply will not untense. And if you practice long enough, they will eventually untense, but that is not their experience at first. And if you give them a progressive muscle relaxation tape that says, and now you feel relaxed, they don't, and it's very frustrating for them. When we do cheerleading, we really want to think about how not to do this in some kind of, global chit-chatty, you're all fine, who's Stuart Smalley, right? He looks in the mirror and he says, I'm a good person and people love me. It's not that kind of cheerleading, right? We want people to encourage the patient very precisely about what is it the patient's doing right now, not generic encouragement, but if I asked you right now to stay at your office, you've called me on the phone, I've given you a skill, I want you to stay at the office, I'm going to say, I really, really want you to stay at the office. You can do this. You can actually sit here for the next hour and 45 minutes and then go home and be free. I'm going to be very precise about it. You assume the best about them. You focus on their strengths. But being realistic about this and what are their genuine strengths? These guys survived often a lot of trauma. They have a lot of strengths. They just often get washed out by all of the sort of demanding and sort of unpleasant behaviors that kind of are layered on top. Being realistic with them, staying near to them. It's very important for these clients to feel that we're right there with them in a very honest and straightforward way, and to contradict or modulate external criticism. These are folks who grew up in an invalidating environment, an environment that invalidated valid things, right? Part of the validation strategy for us is to block that, to modulate criticism that doesn't actually make sense. Now, the other thing we don't do in DBT is validate invalid things. So if I don't agree, if I don't think it's valid, I'm not agreeing with it, right? I might be able to validate how painful it is that, my hospital has a no smoking policy, and they will have to literally be able to leave the unit and be 25 feet away from the entrance to the hospital, and their behavior has been so out of control that nobody is going to let them go outside the hospital 25 feet away from the entrance. It's not happening at this point. There's a valid rule, their behavior validly supports it. I'm not going to say that rule is invalid, but I can certainly validate how difficult it must be to already be in the state you were in that resulted in a hospital, and now you've got nicotine withdrawal. Like, that is no joke. That's a hard place to be. The other thing we do is dialectics. So I've gotten all the way into this talk. We haven't talked about what dialectics and dialectical behavior therapy is. It's based on a philosophical system. Dialectics is a way of thinking and having an intellectual process or an argument that is designed to kind of bring you to a deeper knowing, a deeper understanding. DBT uses a somewhat simplistic version, so if you're a philosopher in the room, this is definitely not capturing all that dialectics is, but it's based on this core idea of dialectics that for every thesis there's an antithesis. For every argument there's a counter-argument, and that the the way that we move forward, the way that we bring new knowledge, the way we bring things together, the way we get to innovation, is by finding the synthesis, the place where the legitimacy of both the thesis and the antithesis can be held together at the same time. That we don't go from an either or, we're coming from a both and point of view. So the most standard one we have in DBT is this idea that you must accept yourself exactly as you are, and you must work as hard and as fast as you can to change. That both of those, this is not an either or, this is not a sometimes one, sometimes the other. This is that at every moment, we need to see the patients that way, the patients need to see themselves that way, we need to see ourselves that way. We need to be able to hold those two opposites in the tension they have together at the same time, because both are absolutely legitimate. So we use validation and mindfulness strategies in DBT to kind of really embrace the acceptance side, and these myriad behavior therapy interventions I've been talking about to focus on the change side. And that really helps folks with borderline personality disorder because there's some really, really core dialectical tensions that they face. This is not a group of people who's good at finding balance. Most of the things we talk about in DBT, we talk about finding a balance, not one or the other. Balanced eating, balanced sleeping, balanced emotional reactions, balanced thinking, the idea that you can really move, again, like I said, from that either or to that both and place. This really, really helps therapists get unstuck, right? So if you are in a situation, with a client where you're getting like this, right? You're not going to get anywhere and they're not going to get anywhere. And in fact, the thing I really worry about is as you're arguing your position, they're rehearsing their dysfunctional behavior. You're saying you need to try to live, and they're like, no, I have no reason to live. No, you have to keep trying to live or we're going to have to hospitalize you. No, I have no reason to live. Right? I don't want them rehearsing that behavior, and I don't want us to be fighting each other. Right? The idea of a both and thinking that gets us unstuck is the problem is out there, and we are both legitimate. We are trying to solve the problem out there. We have to find a way where both of our positions are legitimate. That it both makes sense that you absolutely want to die and you have no hope, and you absolutely need to try harder and do better and be more motivated to change at the same time. And the goal here is to get rid of extremes, right? People with BPD, people who are chronically suicidal, they're characterized by extremes. Extremes in their thinking, extremes in their values, that whole sort of classic, I love you, I hate you, right? This is all very, very extreme, and we're trying to help use dialectics to find a balance. And that's the end of my presentation. So all these pieces come together to create DBT. And if anybody has any questions or comments, I'm happy to discuss them. I'm not sure, Stephen, how much time do we have before people need to get, do people have 1 o'clock so they've got to scoot off too? Yeah.
A question about use of DBT as substance.
Yep.
Does that make it what you're the borderline or where's what's not borderline? Does that make it a little bit harder for you?
Well, yeah, so most of the research on DBT for substance abuse has been with opiate-related addiction, which for these days is actually turning out to be a good thing. Historically, people had not been, there's been some research with methamphetamine as well. The current state of DBT is that it does as well, I would say, or slightly better than standard drug alcohol treatment in reducing the addiction behavior. What you really see is if people are in DBT, they have simultaneous mental health outcomes, more dramatic drops in anxiety, more dramatic drops in depression, so that I wouldn't say that I think DBT has kind of got the kind of got its pulse on the finger of addiction and somehow does better. Certainly not than things like contingency management or harm reduction that have much, I think, more inherently strong data. But if you've got someone with co-occurring disorders where you've got a lot of mental health outcomes that you're trying to treat at the same time, then I think DBT, the evidence is DBT is a stronger intervention.
And I have one more, and that's just computerized. It
It has not yet. There are a couple of studies that have come out recently of different versions of computerizing DBT, and the data looks good, but what I haven't seen is somebody in the tech industry like scale it up, right? We know that there are ways of teaching skills in video and ways of teaching skills on computers that do seem to work, but I haven't seen them scale. Yeah. With say again? Yes. Yeah. So there are versions of DBT that are designed for people with really profound mental retardation or intellectual disabilities. There's a woman, Julie Brown in Rhode Island, who's got a nice system for treating profoundly mentally retarded folks. For borderline mental retardation, what we've found is that you can accommodate them within a standard DBT program reasonably well. What we do in our program at the mental health center is we have a track that we call our cognitive track that runs more slowly for somebody who has a cognitive impairment at the same time as their emotion dysregulation. So folks in there have borderline mental retardation, significant head injury, psychosis, active psychosis that is interfering with their learning capacity, etc. And we run a group only for an hour every week and give people a half hour of individual skills training. We find that helps to not try to do everything in the group, and the pace of the group is slower. So it takes us about 18 months to cover what everybody else covers in a year. And we found with those accommodations, then they do very well. You had a question? By the end of DBT, no. I mean, I have had people where I have been willing to write a letter in support of temporary disability early on in treatment when I'm actually agreeing with them that they cannot regulate themselves to be in a work environment effectively. I would not, the point of a year of DBT is that you should get past that. That the whole point of if the treatment is working, you should be sufficiently regulated. And what we typically find is people who before DBT were failing out of school, who were not able to handle it in a work environment, are dramatically better able to do those things after they learn skills. And frankly, particularly for work, I just think the DBT skills are that set of skills are really good work skills. And I've done some research that I'll talk about as part of the conference tomorrow about developing a program to help psychiatrically disabled people to return to work. But there's been other DBT research done in New Mexico where they've worked with the Department of Vocational Rehab to use DBT skills to help people to work. And I think there's a particular synergy between DBT skills and work skills. Yeah. Well, so we always do what we call pre-treatment at the beginning. So before somebody enters DBT, we have some pre-treatment sessions. Usually in my clinic, that's about 2 sessions. Other places, it can be as many as 4 sessions, where you get background, figure out, do they appear to have emotion dysregulation? Does the biosocial theory apply? Because in general, if the biosocial theory applies, they're probably going to benefit from the treatment. That's one of the real usefulness of that heuristic. So we've seen people with addiction problems or depression or anxiety or other things who've done really well in DBT, even if they didn't have borderline personality disorder. So the question is, do they have a fit? And are they willing to commit to this much work? Because they have homework for group every week that they have to practice on their own. They have a diary card they have to fill out where they track things every day, which is an additional thing. The therapist expects them to do things. So the question is somebody really willing to commit to those things? And if they are, one of the things we always do is commit for a specific duration, usually either 6 months or 12 months. And during that time, unless they miss 4 sessions in a row, we don't exit them from treatment. We just keep going. No matter what, we keep going. But as you approach in the last third of that period, either at 4 months for a 6-month treatment or 8 months for a 12-month treatment, there's a real question, are we going to re-up? Are we going to do any more of this? And people sort of describe DBT in some ways as kind of a blackmail therapy, in the sense that in most treatments, you get more because you're doing worse, right? You haven't improved, so you're going to get more treatment. You're struggling, so you're going to get more treatment. In DBT, we would only re-up if the person had shown substantial improvement, because our feeling is that it's just not ethical to keep doing something that isn't having an effect. So if the person has not been showing up, they haven't been improving, their self-harm is continuing, or whatever they came in for with those problems we're trying to target to get their life to go well, they're not working on all of those, we would not re-up. But that's not a one-time offer. If somebody chose to come back later, we would accept them back at another time, and they could give a case for us as to why things were different. Yeah.
My question is, in that basic area, there's not compliant or not existing.
Mm-hmm.
With this session, you don't do the homework. Those are some that can be homework. Therapy probably having handed them, and are the kind of environment for therapy. What's the dropout rate?
So the dropout rate varies between the lowest dropout rate I've ever seen was 17%, and the highest dropout rate's about 50%. It really varies on the program and who takes the patient in, and what the barriers are to getting in, how complex the patients are that you take. Literally, when I tell you, like, the only way you get out of DBT is to miss 4 in a row of either your individual session or your group session, I mean that completely. We don't exit people. In my 25 years at doing DBT, we have actually had a person where we told them they have to leave once. And she was in this situation where she believed, and we believed, she was going to hit her therapist if this did not. Like, we started having her doing therapy in a room, like a classroom, like a big room where she was physically really far apart, and we couldn't find anything, and we eventually said, I'm sorry, you're just going to have to go, that this is just not going to work. So generally, we will keep them in, and that's why we always have a specific contract period. And then the chain analysis is how we treat the therapy interfering behavior. You didn't show up for group. I'm going to do that minute-by-minute analysis of what happened right before that group, and I am going to figure out what actually happened that you didn't come. Is this because of a belief that you had, an emotion you had, contingencies, your mother didn't drive you? Like, what are the issues? And then we treat the issues. That's essentially how we respond with that chain analysis and the interventions to everything that gets presented to us. Yeah. would say when it comes to the staff who are interacting with them, I consider that something that the unit needs to deal with. And some units have used DBT skills as essentially an employee assistance program, things like that, where truly the staff need the help. And that's what some people have told me. I know someone who was using it in a forensic state hospital where the patients all have antisocial. Actually, surprisingly few of them in her unit have borderline personality disorder. And I said, well, why don't you just use any other behavioral tool? And she said, my staff need the DBT. My staff need the skills. My staff need the skills to rest on. Yes, I don't know that the patients have to have DBT as opposed to another behavioral model, but it works better for us because the staff are more regulated in dealing with them, and so we have less incidents because of that. We have had volunteers, big brothers, big sisters, caregiver, I suppose a CPS worker, but I can't imagine a CPS worker having the time to engage in treatment, come as a surrogate for a parent to the multifamily skills group, for instance, when they don't have someone like that. So I'm aware it's after 1, and I'm worried that somebody has somewhere they have to run off to. So we'll stop now, and then if we can, I'm happy to keep answering questions. Sure.